Assalamu alaikum wa rahmatullahi wa barakatuh. I will speak today about iron deficiency and iron deficiency anemia. Iron deficiency is one of the most prevalent forms of malnutrition. Globally, 50% of anemia is attributable to iron deficiency and account approximately for 1 billion patients and nearly 1 million deaths annually worldwide. These deaths chiefly occur in Africa because of malnutrition and some parts of Asia. Start with, let's review some essential facts. Iron is absorbed from the GIT, chiefly from the duodenum and to less extent the upper intestine. Absorption of iron is subject to the iron type in the food and other factors. These include the pH of the stomach. If there is a chlorhydria, absorption of iron will be impaired. Antacid, proton pump inhibitor, and others that suppress the acidity of the stomach will lead to decreased absorption of iron. The type of iron, we have the heme iron and the non-heme iron. Heme iron, it is the best for absorption. This is present. 30% of heme iron will be absorbed. While the non-heme iron, only 5 to 10% will be absorbed from the non-heme iron. Non-heme iron that is present in vegetable, grains, and fruits. Heme iron present in the fish, meat, and other animal products. In addition, heme iron, if present, it will increase the absorption of non-heme iron. That is, if your meal contains animal source of iron, this in addition to non-animal source, vegetable or fruit or grain source, the presence of heme iron will enhance the absorption of non-heme iron. While some substance in vegetable and fruit and grains will inhibit absorption of iron. Of special note is the tea. Tea will lead to inhibition of absorption of iron, calcium, phytate that presents in whole grain vegetable, whole grain wheat and other grains. Let's take a quick review of the absorption of the iron in the duodenum. This is the lumen of the intestine. Iron will be absorbed to the mucosal cells. Inside the mucosal cells, expression of the iron for transferrin to combine with transferrin is dependent of some hormonal factors. That is some hormones types. Don't want to enter you into unnecessary details. That will allow this iron to enter to the circulation. If the body is not in need for iron, iron will not absorb, will not be secreted from the mucosal cells to the bloodstream. It will stay in the mucosal cells and shed again into the intestinal lumen. Iron is toxic if in the circulation. It's very toxic if it is free. So it should be combined with a transfer protein, that is the transferrin. Transferrin will transfer the iron bound to it to usually stores in the liver or to the bone marrow, where it will be used for by the erythroid precursor to produce red blood cells and also to be stored as a ferritin. Also, transferrin will transfer iron to ferritin, that is the chief storage protein for iron in the circulation and also in the bone marrow. aged RBCs will be destroyed by the reticuloendothelial system, where they release their iron, where it also go to ferritin or shifted back to bone marrow for production of RBC. The only way the body can lose iron is through sweating and through shedding of epithelial cells from the skin, gastrointestinal tract, and urinary tracts. This loss around 1 milligram per day for a male and around 1.2 to 1.5 milligram per day for a female. This is for a female, we account for the menstrual loss. This is the average amount of loss of iron from the body, and this should be compensated from dietary source. First, for the stage of iron deficiency, we have multiple stages. Usually, the body contains stores in the marrow reticuloendothelial irons, that is stainable iron. If we take a bone marrow sample, we have stainable iron. The first stage in deficiency will be the disappearance of stainable iron, no stainable iron. This is the first stage. Well, serum iron will be normal, iron binding capacity normal, transferrin saturation normal, hemoglobin and RBC morphology normal, and ferritin are normal. The first stage will be the disappearance of marrow reticuloendothelial iron. For this stage, around 1/3 of all women in the reproductive stage, the reproductive age has such non-stainable iron. But this is will not manifest iron deficiency. They will be in a critical condition, and any additional or increase in the loss or decrease in the dietary iron will lead to the second stage in iron deficiency. The second stage, soluble iron will be null, but still the serum iron is normal. The iron binding capacity is normal, hemoglobin is normal, transferrin saturation is normal, but there will be a decrease in the ferritin. This is the second stage in iron deficiency, decrease in the ferritin. The third stage, the serum iron will be low, the total iron binding capacity increase, transferrin saturation will decrease, ferritin is also decreased, but still the hemoglobin is normal. Also stable iron, definitely it is null. And the third stage, still the serum iron low, total iron binding capacity high, transferrin saturation low, and now the hemoglobin start to decrease, but still the RBC morphology is still normocytic, normochromic. Definitely the ferritin is low. After hemoglobin decrease from 9 to 13, at this stage still the RBC is normocytic, normochromic. This is the usual. If it is if hemoglobin decrease below 9, there will be microcytic hypochromic. That is the classical type of anemia, microcytic hypochromic anemia. But before that, presentation may be with normocytic normochromic anemia. Also, microcytic hypochromic anemia, microcytic anemia is not specific for iron deficiency. It is not automatic if you find a microcytic hypochromic anemia to say this is iron deficiency anemia. because microcytosis may occur in a number of common conditions like thalassemia. Both alpha and beta thalassemia will have macrocytic RBC morphology with mild anemia. One important thing to differentiate is the RBC count. RBC count in thalassemias, both alpha and beta, will be normal or usually increase. While in iron deficiency anemia, RBC count is decreased. But definitely you need to confirm the presence of iron deficiency by measuring, by other measure we will speak in the next slides. The typical symptom of iron deficiency with or without overt anemia is non-specific and could occur in a number of conditions. It is not specific for iron deficiency. It includes fatigue, weakness, headache, irritability, exercise intolerance, and exertional dyspnea and vertigo. All are non-specific. Angina pectoris or exacerbation of angina, also a feature of severe anemia. One symptom is pica. Pica is a craving for non-food item. This is not specific for iron deficiency. It could occur during the normal pregnancy. Also, it is a primary eating disorder. Could occur as a primary eating disorder. And also possibly other micronutrient deficiency like zinc deficiency and lead poisoning could present with pica. But one specific type of pica, the ice craving, pica for ice. This is fairly specific for iron deficiency anemia. And any patient with pica, you should check for iron deficiency, either iron deficiency without anemia or overt iron deficiency with anemia. Another symptom, the beeturia. This is a red urine after eating beetroot. This is also could occur in around 30% of normal population. 30% of people who eat beetroot will develop red urine. But it is fairly common in iron deficiency. Around 80% of patients with iron deficiency will develop red urine. So keep it in mind. Any patient with non-specific symptom of fatigue, weakness, headache, and bituria or pica of any type, you should check for iron deficiency even without overt anemia. Restless leg syndrome, also this is could be a primary neurological disease or occur due to side effects of drugs, but also occur due to iron deficiency. So keep iron deficiency in your mind when you face with patients with restless leg syndrome. Physical examination in individual with iron deficiency with or without anemia may be totally normal or may reveal one or more of the following. Pallor if there is anemia, a dry and rough skin, atrophic glossitis with loss of papillary tank, good tank papillae, which may be accompanied by tank pain and dry mouth, angular kerositis, fissure at the corner of the mouth, and the more specific cholinichius, wound, nail. This is specific for iron deficiency, but it occurs usually late in the disease after development of overt anemia. Other rare symptom signs is esophageal web. That is the Plummer-Vinson syndrome. This is esophageal web accompanied by dysphagia occur during prolonged or severe iron deficiency anemia. Usually this is pre-malignant. You should take a biopsy to confirm that this is just a benign esophageal web and did not develop a malignancy. Alopecia is also one of the rare manifestations of severe iron deficiency. Now, how could we diagnose iron deficiency? Serum ferritin is usually enough for the diagnosis of iron deficiency anemia. Normal serum ferritin range from 40 to 200 nanogram per ml. Serum ferritin usually the only things what we will need to diagnose iron deficiency anemia. Iron deficiency anemia is confirmed if serum iron less than 15 nanogram per ml, or if the serum ferritin less than 41 nanogram per ml and there is anemia. Anemia, as I told you, it is less than 13 in male or less than 12 in female. This is the definition of anemia. Okay. If we find anemia and serum ferritin less than 41, this is confirmed iron deficiency. There is cases where it is difficult to differentiate between iron deficiency anemia and anemia of chronic disease, especially patients with a chronic disease with inflammation. So in this difficult case, we should calculate the transferrin saturation. Transferrin saturation calculated by serum iron over total iron binding capacity multiplied by 100. This is the transferrin saturation. You should check the serum iron, total iron binding capacity, and calculate the transferrin saturation. And also we should check the C-reactive protein. Iron deficiency anemia in such case is confirmed if transferrin saturation less than 10% or transferrin saturation less than 20% with evidence of inflammation, i.e. high C-reactive protein. Also, you should note that if C-reactive protein more than 80 milligram per ml, divide the ferritin value by 3. For example, a patient with rheumatoid arthritis, his C-reactive protein is 100 milligram per ml. He has anemia HB9. That is normocytic normochromic. This is anemia of chronic disease, or this is iron deficiency anemia. We go to check ferritin. Ferritin, which found ferritin to be 90. If we look to the definition, this is not iron deficiency anemia, but because C-reactive protein is more than 100, divide the serum ferritin by 3. It will be 30. So this is confirmed that this is iron deficiency anemia. Now, if we diagnose iron deficiency anemia, how we calculate the amount of iron needed? There is multiple equations. The simplest is this one: total body weight in kg multiplied by 2.3 multiplied by 15 minus patient's hemoglobin. You can also add 500 to 1000 milligram to replenish store. There is controversy. Some experts prefer to replenish only the iron deficit. Some prefer to replenish also iron store. That will be 500 to 1000 milligram. Let's take an example. If the hemoglobin is 7, the patient's weight is 70 kg, so the amount of iron needed will be 70 kg plus 2.3, this 2.3 plus multiply by 15 minus hemoglobin 7 minus, it will be 1288 milligram of elemental iron. We will speak about what we mean by elemental iron. If we need to replenish the store, we add 1000, will be 2288 milligram of elemental iron that is needed to replenish the deficit in the store. Oral iron therapy is usually cheap and feasible for most patients. But remember that if the patient has gastroesophageal disease, like inflammatory bowel disease, Crohn's disease specifically, that prevents absorption, celiac disease, or chronic atrophic gastritis, absorption from GIT will be affected. So you should know to decide to start with the iron. For other patients population, oral route is preferred because of it is cheap and simple. But remember, if you choose the oral route, oral iron preparation that is proven clinically and tested clinically is the ferrous fumarate, ferrous gluconate, ferrous sulfate, and polysaccharide iron complex. There is enteric coated preparation and sustained release preparation are not helpful because it will release iron away from duodenum and upper intestine for absorption. Also, other polypeptide like polypeptide iron, it is should not be used because it is expensive and not tested clinically. For these type of preparation of iron, remember that the weight of the tablet is not the same as elemental iron. Elemental iron that is available for absorption differ. For ferrous fumarate, for example, 33% of elemental, there is 33% of elemental iron per milligram. For example, 325 milligram tablet will contain 106 milligram elemental iron. For ferrous gluconate, it is 10 to 14%. That is for ferrous gluconate. If you choose to give 325 milligram tablet, keep in mind this will give you only 36 milligram elemental iron. So keep in mind this in mind if you are choosing to give oral iron. Polysaccharide or iron complex, the amount of elemental iron is the same. If it is 50 milligram tablet, it will contain 50 milligram elemental iron. When you give iron supplement, what response you should expect? The typical response for iron supplement is the immediate disappearance of pica, especially child and adolescent with ice pica. When they start the first tablet, the pica will disappear. The next will be improvement in the feeling of well-being within a few days of starting the treatment. Then there will be a modest reticulocytosis, peak approximately 7 to 10 days after starting iron therapy. Then hemoglobin concentration, remember this, hemoglobin concentration will start to rise slowly and usually begin after approximately 1 to 2 weeks of treatment only, and will rise approximately 2 gram per deciliter over the next 3 weeks. That is, if you give iron, check it after 3 weeks. It should be raised by 2 gram per deciliter, not earlier. The hemoglobin deficit should be halved by approximately 1 month. And the hemoglobin level should return normal by 6 to 8 months. You will not expect to get a complete response within a few days. It will start to rise 1 to 2 weeks. It will need 3 weeks to increase by 2 gram. If it is, let's say, its hemoglobin is 7, after 3 weeks it will be 9. This is typical response. So remember this if you decide to use oral iron, especially in pregnant women near the term. This will be very, very slow. So you need to use intravenous iron instead. The deficit for will be halved by 1 month and require usually around 2 months for to correct the the full deficiency. After you correct full deficiency, you need for 3 to 4 months of continuous supplement of iron to replenish iron store. Lack of response. If there is lack of response, ensure that the patient compliance. Oral iron is associated with unpleasant side effects like constipation, metallic taste, nausea, gastric pain, diarrhea. So a large proportion of patients do not take oral iron. This is exclude patient in compliance if there is lack of response. Also check if there is an adequate dose. As I told you, you check the tablet, how much it contains of elemental iron. And if there is malabsorption, like in celiac disease, hidden or asymptomatic celiac disease, or chronic gastritis, or concurrent therapy with antacid or others. Keep in mind, if you're giving oral iron, give it in separation away from food, either 1 hour before food or 4 hours after food. Other cause of lack of response is blood loss exceed iron intake. Continue blood loss due to the original disease that cause iron deficiency. Iron deficiency is a symptom of other disease. And the fourth is incorrect initial diagnosis. This is occur frequently if you don't if you diagnose microcytic hypochromic anemia as iron deficiency anemia and start treatment of iron, and turned out that this is a thalassemia and not an iron deficiency anemia. Keep in mind also, alpha thalassemia is not usually detectable on electrophoresis. Electrophoresis will be normal. Only beta thalassemia is detected on electrophoresis. So from the start, try to get correct diagnosis. If you check the patient compliance and you want to be sure he has no malabsorption, there is one test, simple test called iron tolerance test. How we perform this? You bring the patient fasting to your office, check serum iron, then give 2 iron tablets, then check serum iron in the next 2 to 3 hours. Baseline serum iron, and then after 2 to 3 hours, serum iron. After you give 2 tablets of iron. Normal absorption will result in increase in the serum iron of at least 100 microgram per deciliter. 100 or more. If there is no such increase, this is mean there is malabsorption or some form of resistance to oral iron. So you should shift your parenteral or intravenous iron. Intravenous iron therapy is usually the newer preparation is usually safe, but you should keep in mind the following points if you decide to use iron therapy. Iron therapy intravenous will result in a flare of arthritis in patients with inflammatory arthritis, like rheumatoid arthritis and ankylosing spondylitis. If the patient with chronic inflammatory arthritis, intravenous iron therapy will result in a flare of arthritis. How to treat? how to treat, use a steroid pre-medication or a brief pre-medication like methylprednisolone before you infuse the iron, or a brief course of steroid after infusion to avoid exacerbation of arthritis. The second point, severe infusion reaction in patients with bronchial asthma or multiple drug allergy. If the patient have multiple drug allergies or bronchial asthma, there will be a severe infusion reaction. So use pre-medication with the steroids, for example, as we said, methylprednisolone, 125 milligram, to avoid this reaction. So there is a theoretical risk of exacerbation of infection. So avoid iron therapy during active infection unless it is specifically and evidently indicated. Now, if we diagnose iron deficiency, we should check the cause of iron deficiency. In general, iron deficiency, some causes are obvious, like increased demand for iron during rapid growth in infancy and adolescent and in pregnancy. Increase the blood loss, like increase iron loss, like an increase in chronic blood loss, like patients with bleeding hemorrhoid or heaviness or acute blood loss for any cause or multiple blood donation. Here, the cause of iron deficiency is obvious. Decrease iron intake or absorption, like inadequate diet, malabsorption, like celiac pro and Crohn's disease, or malabsorption from surgery, gastrectomy, and some form of bariatric surgery for obesity. This is nowadays very common and results in iron deficiency. And also acute and chronic inflammation. So if you face a patient with iron deficiency, if the patient is pregnant woman, growing child and adolescent, or there is a frequent episode of bleeding from hemorrhoid, from other causes, from bleeding of the peptic ulcer, or an adolescent with inadequate dietary intake. Keep in mind with the adolescent with low weight and adolescent with obesity also. Patient with obesity, adolescent with obesity, usually dieting in a regular manner and avoid animal products, so they are at risk of iron deficiency. Obese and thin patients both are at risk for iron deficiency. If there is nothing from this, especially the patient, male patient or female patient after menopause, start to check dietary history. If he is using, if he has a problem with animal product, chronic use of non-steroidal leading to peptic ulceration or anticoagulant, and also check for personal or family history of celiac disease. Sometimes silent celiac disease will present only with iron deficiency anemia. So checking for anti-tissue transglutaminase, anti-tissue transglutaminase is a must in any patient with unexplained iron deficiency anemia. Also keep in mind the colorectal carcinoma. This is very important cause of iron deficiency in elderly and in postmenopausal women. Test the stool for occult blood in patients 50 years of age and older looking for occult blood loss. Any patient with iron deficiency that is older than 50 years, he should undergo full GIT assessment because the most common cause will be GIT malignancy. So if he has our GIT symptom, gastroscopy is indicated. If he has laryngitis symptom like constipation or recent diarrhea, colonoscopy is a must. Both, if it is negative, you should do the other test. If you start with the gastroscope, you should go to colonoscope. You should exclude gastrointestinal malignancy. And also, as I said, you should exclude silent celiac disease. Also, keep in mind the hookworm. Hookworm is very important and the most common cause of iron deficiency worldwide. Ankylostoma duodenale in the Mediterranean area is the type of hookworm, and Decatur americanus in the North and South America. For hookworm, the diagnosis is by detection of the eggs in the stool. But remember, this is very difficult, and usually the lab personnel lack the expertise to detect these eggs. So, unexplained eosinophilia may be the clue for the presence of parasitic infection, and the stool examination may show the characteristic charcot-laden crystal. Charcot-laden crystal. You will not find the eggs of the parasite. You will find unexplained eosinophilia on blood film and the charcot-laden crystal on stool. So it is simple. Start the treatment with albendazole or mebendazole if you suspect hookworm infestation.